Welcome to the iHF meeting and especially to this session dedicated to advances in the management of heart failure beyond the 4 pillars. So for this session, I have the great chance to be with colleagues and experts. Shelley Zieroth from Canada, Gianluigi Savarese from Sweden, Biykem Bozkurt from US, and Alexandre Mebazaa from Paris, France. So this is a disclaimer, and this session is supported by a Medtronic. And here you have the disclosure of the 3 speakers. And without any other comment, I will hand over to Shelley for her presentation.
Wonderful. Thank you so much. It's an absolute pleasure to be here all the way from Canada. And I think this is such an important topic, addressing really what I consider device optimization, really moving beyond the pillars. It's an opportunity for us to discuss something that's often neglected. And I'm very proud to introduce you to the concept of the DirectHF program, Device Rhythm Management of Cardiac Therapy in Heart Failure. This is a global, needs-driven, patient-centered educational program. And I will show you actually some of the practical guidance that we've generated from this as part of the opinions of 16 top international experts, as well as persons with lived experience. And this, of course, is part of the global education program curriculum that has been developed. We have tackled the challenging concept of guidelines for personalized care and patient management in terms of cardiac devices. We have also talked about the appropriate use. There's been a lot of debate in the era of 4 pillars of HFrEF therapy, when to refer patients. We are talking about barriers in real life. Our surveys addressed many of those issues. And we are looking at the re-emphasizing the key role of cardiac rhythm management devices and really having a close collaboration between heart failure specialists and EP specialists and rhythm specialists. So this is really important. Again, this is an international working group, which we've had educational needs assessment, and we've developed a wonderful program curriculum that I'm going to give you a QR code to get ready to scan, so get your phones ready. These are all of the members of DirectHF, but look at the number of patient associate representatives from across the world, as well as their larger associations as well. So we're very proud of this body of work, and it's chaired by Javid Butler and Cecilia Lind. Now, we started off with a healthcare survey, and we are completing a patient survey. We've done an expert consensus document. We've done global educational webinars. This is part of a further global curriculum and a website that I'm going to introduce you to here. This QR code will take you to the DirectHF website, which contains useful tools for you, as well as some of the publications which I'm going to show you. It introduces you to the members of the DirectHF team, and I think you'll find this a really useful resource. So scan that QR code. I'm going to leave it up for another second here because I think this is a wonderful knowledge translation tool for everybody who's joining us here today. So this is a wonderful document. I'm going to show you a figure from this document at the end of the presentation, so you're going to have to stay tuned for that. But this was published in the European Journal of Heart Failure. This is a consensus document about the timing and the role of optimal use of cardiac rhythm devices in our patients with HFrEF. So download this. It's a wonderful reference document for you. And I'll hand it over.
Thank you very much, Shelley, for this very comprehensive introduction about the DirectHF program. So now it's my great pleasure to introduce Gianluigi Savarese. We will discuss about a very important topic because patients with HFrEF should receive the 4 fantastic, as we call them, the 4 drugs. But also there are devices could be helpful with the medical treatment. and usually the devices are underutilized. So, Gianluigi, thank you very much.
Thank you so much, Christophe, and for the invitation being here today. So first of all, why do we still need treatments and new treatments, new interventions to be tested in patients with heart failure? Well, you can clearly see here some key epidemiological facts regarding the disease. Heart failure still represents a global pandemic with more than 60 million individuals worldwide living with the disease. And this is going to become more and more a problem over the time because the population is growing and it's aging. And of course, this leads to higher prevalence of the disease worldwide. Together also, of course, to changes in comorbidities and risk profile of people at risk of heart failure. So heart failure stays a key topic in the healthcare setting. And how do we treat patients with heart failure? Well, multidisciplinary and integrated care is really the key. We see very clearly that many different healthcare providers are involved in the care of these patients, starting, of course, with heart failure specialists, the electrophysiologists, but also nurses, pharmacists, general practitioners are involved in the care of these patients. Why that? The reason is that the treatment is actually a very, let's say, include different interventions. We start with medications, but then we must consider devices. But some specific patients even need surgery. Lifestyle interventions are important for all, and management and monitoring stay a key a factor for all patients. So multidisciplinary team is key. We need to start to treat this patient with medication first. You were indeed, Christophe, speaking about the 4 pillars. The 4 pillars are class 1 recommendation according all the guidelines. It's indeed what we really need to start with. But there are also some issues related to using the 4 pharmacological therapy in patients with heart failure. First of all, not all patients might tolerate all the 4 pillars or neither the target doses of this medication. So the first concept is we should really not talk about target doses, but rather the maximum tolerated doses of these medications. Why is that important? Because very often we recommend devices where optimal medical treatment is achieved, and optimal medical treatment is not target doses of all the 4 medications for all the patients. Some patients might not. So this is a first key aspect to consider when we evaluate actually an indication for a device in these patients. And indeed, as we can see in this slide, in many different registries worldwide, we clearly see that on all patients, not all patients, receive quadruple therapy at target doses. One reason is, of course, clinical inertia, but as I was reporting also earlier, many patients might indeed not tolerate target doses. And therefore, whether we wait for achieving target doses for then implanting a device, maybe we will just wait forever because these patients might never be on target doses of medication. But when should we consider devices in patients with heart failure? And here we focus on ICDs for primary prevention of sudden cardiac death and CRT. So we try to provide, first of all, in the DirectHF, we try to summarize the current recommendations for actually devices in patients with heart failure. We make very clear in this figure that, first of all, we need to think about optimizing medical treatment. So you see optimizing the use of ACE and ARNI, beta blockers, MRA, and SGLT2 inhibitors. Of course, loop diuretics might be needed for fluid retention. And then in order to phenotype the patient in the right way, in order to understand the right device for the right patient, we need to look, first of all, at the ejection fraction. Well, whether it's equal or lower than 35%, there is an indication for a CRT or an ICD, depending on the QRS length. So based on that, we might decide whether we might need a CRT, a CRT-D, a CRT-P, or an ICD which at the moment has different actually class of recommendation in patients with non-ischemic and ischemic heart failure, as you can see on the left in this slide. Why devices are important? Devices are important on top of pharmacological treatment, and this is very clear in this real-world study, very recent study. So we are used to say that the evidence on devices is outdated. Trials were quite old, so we really don't know if these devices are still show efficacy nowadays. But if we look at real-world data, we might see that whether patients have pharmacological treatment on board, the devices, whether is implanted, will lead to further improvement in survival and depending on the device, of course, for CRT also lower risk of heart failure hospitalization. So the key message here is, of course, start and optimize quadruple GDMT, but not forget that then you need to consider indication for ICD or CRTP and D, and in the next few minutes we will see when, and quadruple therapy plus device therapy is class 1 recommendation in all international guidelines.
Thank you very much, Gianluigi, for this very nice talk. I think one of the key messages is that drugs and devices are not in competition, but they are combined therapy for them. So now it's my great pleasure to welcome Biykem, who is in online today. She was not able to join us, and she will deliver about a very important topic, and I would say a misunderstanding in the community, especially the heart failure community sometimes. It's about current pharmacological therapy as dramatically you reduce the risk of sudden arrhythmic death. But you will see that this risk is still present even with optimized medical treatment. Thank you, Biykem.
Hello, everybody. I am Biykem Bozkurt, and I will be presenting on a topic that is crucial, one of the commonly quoted misconceptions. And I will try to dispel the misconception that current pharmacological therapy has dramatically reduced the risk of sudden arrhythmic death. There is a perception that the risk of sudden cardiac death in patients with heart failure with reduced EF is declining. This is partially due to the expansion of the guidelines, which now include the 4 pillars of therapy that include RAS inhibitors, SGLT2 inhibitors, beta blockers, and mineralocorticoid receptor antagonists, known to improve outcomes, and some proven to reduce sudden cardiac death and result in reversal of remodeling. Some editorials have suggested that sudden cardiac death, especially arrhythmic sudden cardiac death, is no longer a significant risk for patients with heart failure that are treated with guideline-directed medical therapies. But in this talk, I will try to underscore the importance of the residual risk of sudden cardiac death and the necessity to incorporate device therapies with ICD into the orchestration of guideline-directed therapies, which include ICD in patients with heart failure with reduced EF. Let's start with the reported trends, such as the one shown on this slide regarding the sudden cardiac death rates reported in the randomized clinical trials in heart failure. As shown on this slide, there have been reports stating that the sudden cardiac deaths are reported to decline over time in the randomized clinical trials. It should be kept in mind that in 1990s, the patients enrolled in the heart failure trials were much sicker, with more advanced NYHA class, lower EF, most without ICD, and most represented higher rates of mortality. If one were to compare the trials with similar severity of illness, the trends for sudden cardiac death actually remains similar over time, as shown by the orange line. The second important point is that the residual annualized rate of sudden cardiac death risk across studies is still very high, 3.75 as shown on this slide, which is considerably higher than the 1 to 2% rate that is cited in patients with hypertrophic cardiomyopathy, most of whom have an indication for ICD. If we examine the rates, the sudden cardiac death rates reported in clinical trials as shown on the left, the residual risk of sudden cardiac death, even in the contemporary heart failure trials, remain at 2.53% per 100 patient years, which is a significant risk for death. And more importantly, the proportion of death attributed to sudden cardiac death remains 35 to 39% of all mortality in heart failure trials, despite the guideline-directed medical therapies. Even in the contemporary trials, the use of ICD is still associated with a lower risk of sudden cardiac death. As shown on this slide, in the PARADIGM-HF trial, ICD therapy was associated with a 56% lower risk of sudden cardiac death in patients meeting the eligibility criteria for primary prevention of ICD, irrespective of the heart failure etiology, including those individuals with ischemic or non-ischemic cardiomyopathy, even after propensity score adjustment. Recent large-scale population-based studies also demonstrate the continued benefit of ICD therapy in real-world patients, with significant reduction in sudden cardiac death rates in individuals with heart failure with reduced EF treated with contemporary guideline-directed medical therapies. Shown on the left side is the data from a large Swedish cohort of patients with heart failure with EF less than 40%, that demonstrate a 12% reduction in all-cause mortality in individuals treated with ICD compared to propensity-matched controls that are not treated with ICD. On the right side is the evidence from a large cohort from Europe of patients with ischemic cardiomyopathy and EF less than 35%, where ICD therapy was associated with a 32% reduction in all-cause mortality. And in another real-world contemporary analysis, approximately 48% of the first-time ICD recipients received appropriate therapy with either ICD shock or ATP therapy, majority of which could be life-saving, and this was seen over a follow-up of 7 years. These data underline the importance of continued benefit with ICD despite guideline-directed medical therapies in the contemporary era, and that we need to remember ICD therapy is recommended as a class 1 indication in the heart failure guidelines, and ICD therapy is part of the guideline-directed therapies in patients with reduced EF. I will now pass it on to Dr. Gianluigi Savarese, who will talk about the timing of referral. Thank you for your attention.
Thank you so much, Biykem. We go through the next part of the presentation. Okay, so we will talk about misconception number 2. So as medications improve remodeling indices, the timing of referral for device should be reconsidered. So actually, we all agree, I think here, that actually GDMT, so pharmacological GDMT, I think that's the right term we should use, because as we say, devices are also part of the GDMT, might lead to remodeling, which in turn leads over the time probably to less patients in need of receiving a device. This has been demonstrated in few studies. Here you see, for example, the HFrEF trial, patients were on sacubitril/valsartan. You see that at 6 and 12 months, remodeling happened in a number of patients, and this led to less being in need of receiving a device. And this is for sure true, and that's why we always recommend to start first with pharmacological treatments, and after 3 months consider actually a device. But are all the patients the same? Probably not, because when it comes to, for example, ICD, patients are at different risk, for example, of arrhythmias, or they have a different chance of recovering ejection fraction after initiation of pharmacological treatment. So what we are really recommending here is a more phenotyped approach to referral and implantation of devices, and of course choosing the right device for the right patient. For example, you will have patients with very high risk of ventricular arrhythmia and sudden cardiac death, and in these patients, maybe you might not need to wait that long before implanting a device and playing that much for achieving what we call target doses. And I already explained why we should not focus that much on target doses, but on maximum tolerated doses. Some patients might have so low ejection fraction that it's very unlikely that they might recover EF with pharmacological treatment. And some of them might have ischemic heart disease and such an extensive myocardial scar, which makes quite impossible to recover ejection fraction. And so in specific phenotypes of patients, probably we should even reconsider the timing for implanting a device after initiation of a pharmacological treatment for the prevention of sudden cardiac death, and therefore we speak about ICDs. And this is therefore the approach which we do recommend in the DirectHF approach here reported in this slide. You see that here we have an algorithm which is more patient-centered. So we propose different algorithms for referral and for implantation of device based on the specific phenotype of the patient. In the patients with chronic heart failure initiated with pharmacological treatment, of course, as all the guidelines do, we recommend initiating pharmacological treatment waiting 3 months before referral. But in patients who are at high risk of life-threatening arrhythmia, we really do recommend not to wait that long and start directly with an immediate referral in a way that the patient is already in the right setting, whether an early implantation of the device is indeed needed. There are also patients who have arrhythmogenic cardiomyopathies. These are patients at very, very high risk of sudden cardiac death. And although these patients might have non-ischemic cardiomyopathy, these are patients who are really in need of an immediate implantation, and therefore we should not really delay referral while we are setting pharmacological treatment. And again, as I mentioned earlier, whether patients have very low ejection fraction and an extensive scar because of ischemic heart disease and revascularization is not an option, then once again we should consider an immediate implantation of the device at first line intervention. This is of course valid for ICDs, is more considering the patient and the different features that might really trigger a more phenotype-oriented approach to the referral and implantation of devices. When it comes to HFrEF and therefore indication for CRT, we should not really forget that patients with a left-bundled branch block and very broad QRS have less likelihood of recovering ejection fraction after initiation of pharmacological treatment. So after our 3 months of pharmacological treatment, whether there is no improvement, we should not really wait long. We should really not delay implantation, because delaying implantation is associated with worse outcome. You clearly see in the study on the right, in the tarot, that whether patients stayed longer with an ejection fraction less than 35%, they were at higher risk of mortality. You clearly see that whether the implantation is delayed, this leads to a higher risk of all-cause mortality and higher risk of heart failure hospitalization. So longer you wait and you expose your patient at higher risk of outcome. We have also very recently shown this data in the Swedish Heart Failure Registry. This is a study from my group, where you can see more or less a dose-response curve between the number of months you wait before the implantation and increasing risk of heart failure hospitalization and cardiovascular mortality, whether indeed you delay the implantation of the CRT and there is an indication for the CRT. We should not forget one thing. I was speaking about the target doses and maximum tolerated doses. So as I said, some patients do not tolerate target doses. In those patients, you take a decision when you understand you can optimize more medical treatment, you implant a device. There is one reason more you should implant a CRT in this patient, and you should not delay it to try to achieve more higher dose of medical treatment. The reason is, as we show in this study from the Swedish Heart Failure Registry, that CRT itself might work as an enabler for optimizing pharmacological treatment. Of course, whether you implant a CRT in these patients who are not fully tolerant for medical treatment, you might use a remodeling, blood pressure might go a little bit up, there might be better renal perfusion, this leads to higher blood pressure, you might be able, after the implantation of CRT, to push a little bit more with optimization of medical treatment, and this is actually leads to even better outcome after the implantation of the device, this time mediated also by an improvement in use of pharmacological treatment. So these are the reasons why we really suggest a new model, as also reported in this position paper from the HFA and ERA, for integrated use of devices, wherein devices are considered early during the heart failure disease course and used in combination with drug therapy. Because as we say, GDMT is not only pharmacological treatment, but pharmacological treatment plus devices.
Thank you very, very much. I mean, we heard so many great lectures. And Shelley, I'm going to start with you because you did a great presentation to show how we are working in silo and how we really need to work together. However, if I am a heart failure specialist, I am alone in my hospital or I am in a private practice, how do you see my interaction with EPs while I am alone or maybe with 2 or 3 heart failure specialists? How do you see this extension and the way we can communicate? Should we meet like once a month? Should we? How do you see we can really do the best for our patients?
Yeah, I think the model is different depending on if you're community or an academic center. I have the luxury right now of my PACER clinic where my patients get interrogated for their ICDs and CRTs right next door. So it's very convenient. So if I think that they've had symptoms, an arrhythmia, a therapy, I can get that integrated quite quickly, or interrogated, quite quickly. I do think that the technology which allows remote interrogations is really quite remarkable and is probably underutilized and is probably another way in which community cardiologists can have a better connection and communication with their electrophysiology colleagues. It's challenging to have simultaneous clinics because of the implant schedules and the clinic schedules, and it gets a little complicated. I think, having somebody that you could open or reach out to regularly is important. So either the on-call person or your go-to person is really important for us to have the discussions. I think the most important discussion we should have now is about timing with our EP colleagues. Heart failure cardiologists tend to be a little slower with referral, and this is something that we really need to change. And I think Gianluigi presented some really important data to show that there is a risk. The sooner we refer, the better outcome for our patients as well. So it's personalized, just like it's a personalized approach to the patient, it's a personalized approach with that collaborative relationship with your electrophysiology colleagues.
How many patients that you see would you send to the EP? Is like 15%, 20%? And I think what people would like to know is why those patients, why not the others? What are the criteria? This will help us a lot.
Yeah, so I think that EF, there's a great slide that summarizes, at the very end I'm going to show you, that summarizes, it's a great tool. It should be up in everybody's clinic actually, because it's not just physicians that refer, it's the nurses, the nurse practitioners are identifying these patients who are on GDMT or aren't tolerating further up titration, their EF is less than 35%, and there's, I think, different urgency criteria, which and you started showing that, Gianluigi. It was great slides to think about. What percentage? Again, I think it depends on the type of clinic you have. My clinic includes patients who have advanced heart failure, are being considered for other advanced therapies like transplant and VAD down the road. So our percentage of patients who are referred for ICD and CRT optimization will potentially be higher than a community cardiologist practice that may have some HFpEF patients in it, right, as well. So they're not in the ejection fraction range for a primary prevention device. So I hate to give a percentage and let people think that they're not doing it. Any referral is a great referral. And if you're under an advanced heart failure therapies percentage, that doesn't mean you're not doing a great job.
Yeah, I completely agree with what you are saying. And we should not forget that not all doctors and colleagues are working in university hospitals. Some may not have access to the IP or the colleague implanting a device next door. And that's where I think DirectHF is particularly important, because providing guidance regarding the timing for referral and implantation is important. I think we should not just consider when referring the patient, but I think it's important to consider when to start a discussion also regarding the timing for referring the patient. For example, I think nowadays all the electronic health record systems in Europe and in many countries worldwide facilitate the interaction between different hospitals and clinics. For example, in Sweden, we are very much used to communicate by referrals and asking to colleagues in other hospitals, well, do you think that this patient should be recommended for CRT or not? So, well, I think it's important to use the expertise of the colleagues also in the hospital next door, and whether you are not sure, basically ask for guidance. I think checking the DirectHF document is important, and then if you don't have in-house the knowledge and you are not sure about referring or not because you don't want to show that you are not doing the right thing to the colleague, just like ask and go ahead.
I would say some of the referral forms are outdated as well. They haven't been updated for the last 5-10 years. The EF criteria are not in keeping with contemporary guidelines as well. Not all of us are as quite electronically linked as you are in Sweden. So there's still that reliance on paper. And so I really encourage people to go to the DirectHF website as well to get with the contemporary guidelines and update their current practices.
I think that we definitely have a need of education, not of the patient, but of the physician. Because even a country very well organized like Sweden, when you look at your registry, about 1/3 of the patients we should receive an ICD really get an ICD, even in your very well-structured country. So I think that today there is some, I would say, some misconception about ICD as well. ICD is like a very dangerous device, but now we have new devices, subcutaneous, extravascular ICD. So it's a little bit more simple with less transvenous lead. So I think that we have, as a physician, we have to try to educate our colleagues. And I fully agree with you that with the new technology, we are all in academic hospitals, so it's very easy to knock at the door of our colleagues. But I think, and we try to do this in our community hospital as well, to have interaction using Zoom or other devices. But I think that we have to discuss about that. I have a question also for you, and it's very important because we have the indication and we have the guideline based on very old study, but now we have new criteria. And you show in your presentation, for example, fibrosis is important. Genetic also is important. We have a patient with non-ischemic cardiomyopathy, history of familial cardiomyopathy. Probably we have to focus on genetic testing. So is it in your clinical practice?
Oh, definitely, yes. I think the guidelines are important, but we should not forget that we are physicians and we should actually apply our knowledge. And our knowledge led to this document is like understanding the risk of sudden cardiac death, for example, is much more than only ejection fraction. It's also understanding how much fibrosis is there, understanding whether there are genetic variants which are associated with higher risk of sudden cardiac death. And this leads to familiarity as well. We should not forget to talk to our patients to understand what happened in their family in the past and so on. So phenotyping patients is considering all these aspects at the same time. And I really think, for example, nowadays in 2026, in most hospitals, you have easy access to MRI. So why don't you check for fibrosis in your patients? Also, genetic testing is becoming extremely simple to be performed. So in case there is uncertainty, if you follow our document and you understand by following our document that some categories of patients deserve a little bit different attention in specific timing on their disease, you will find actually the right action to perform at the right moment.
We have a question from the audience about a patient in whom you discover a non-ischemic cardiomyopathy with ejection fraction 25. You start the pharmacological treatment, so you expect that the LVEF will increase in a few months. So, but this patient is still at risk of sudden cardiac death. So the question is, what is your strategy during the optimization of the medical treatment?
I discuss the potential need for referral for a device at the very first visit all the time. So I let them know our job here is to put you on medications to see if there's an improvement in your heart function, evaluate your overall risk for clinical events, and if appropriate, we will refer you for the appropriate device after discussion with you. So I put it in their head early on that it's not just about medications. There may be a referral required as well. And then, you know, depending on the patient, I most often discuss goals of care as well. So the team members have an idea, you know, is this patient interested in an ICD referral when the time comes or not? And we always make sure we have an EKG at the first visit, which sort of guides, again, whether or not this is going to go a CRT direction or not. So I introduce it right at the beginning as a concept for something that needs to be reevaluated within a few months in the majority of patients. Sometimes we take a little bit longer, but the majority we look at within about 3 months.
I completely agree, and in most patients, for example, we of course discuss as soon as we meet the patient the first time which kind of plan we might have for the next months. In patients where we perceive the risk might be particularly high, we perform also all those diagnostics which might allow further and better risk stratification. So once again, an MRI for understanding the extent of fibrosis. And sometimes also we perform recording of the ECG over 24 hours to understand whether there are specific arrhythmia and so on. So based on these parameters, we can better stratify the risks and actually also understand how aggressive and fast we need to be with up titration in order to not keep the patients exposed to risk for so long while waiting for optimizing medical treatment.
And we have also to keep in mind that in some patients, wearable cardiodefibrillator could be also useful during the timing of this potential improvement in left ventricular ejection fraction. And so it's not a definitive device, but at least the patient is protected.
Gianluigi, you said during your lecture several times, GDMT cannot be tolerated, GDMT is maybe tolerated, we need to pay attention on toleration. What do you mean exactly by toleration? Because at least we have 4 drugs. I think we all agree that SGLT2 is
easy to tolerate.
Easy to tolerate, then already it's not all GDMT. MRA, we know it's more maybe potassium, although we know that combining the two can help. Then when we are saying, all of us, when we are saying GDMT intolerance, are we talking about beta blocker, ACE-ARNI? I mean, can you define this? Because really...
All of the above, right?
Exactly.
Yes, exactly.
People who are listening to us, they would like to know exactly when they should think intolerance.
Of course, it's blood pressure, it's renal function, it's potassium levels, it might be bradycardia with beta blockers. So all these very simple parameters that should be always checked in our patients. And we should also, we should talk to our patients, because sometimes a patient has 100 systolic blood pressure, but no symptoms. So, well, we can try to push a little bit more on medical treatment, but there are patients with 105 and they feel dizzy because of medical treatment. So it's really, there is no one approach fitting all these kind of patients. So speak with patients, of course. Measuring these important parameters is important. Some medications are better tolerated, some medications a little bit less, but it's not always we see all patients tolerating, full dose of sacubitril, valsartan, beta blockers.
We have a lot of heart failure nurses listening to us.
Right.
GDMT intolerance, is it something that can be only diagnosed by physician? Or can we have the heart failure nurses? Can you really tell us that really the heart failure nurses can do it?
I'm such a big fan of the heart failure nurse-led clinics in Sweden. I think they really run most of the show. Nurses can do as well as doctors, in my opinion, even better, for actually rapid up titration of medications, very often also understanding whether there is fluid retention and management of diuretic therapy. And therefore, in Sweden, it happens extremely often. As a doctor, I see the patient the first time, I prescribe medication to start with, I define the diagnostic algorithm I want to follow, but over the next 3 months, the entire work is just done by the nurse. So after 3 months, in most of the case, I will have from the nurse the patient on quadruple therapy with very high doses of medication.
Yeah, and I would add, we have a lot of nurse-led clinics in Canada as well. They're algorithm-based, and that increases the success rate, in my opinion. But I think it's important to communicate to your EP team as well that you're referring to them because you can't up-titrate to target doses, that they're not tolerating GDMT. Because I've had some very keen colleagues push back and say, you have not maximized their MRA or their beta blocker, et cetera. So make it very clear when you're referring that that's the reason why you're doing it as well, because there's keeners out there who want us on target doses of GDMT, and you have to make it very visible. And the other thing I think we haven't really touched on during these presentations is the patient that doesn't tolerate GDMT sometimes also has a significant burden of mitral regurgitation.
Right.
And so, CRT in particular reduces the burden of mitral regurgitation. And so that can be a big game changer for these patients in terms of ability to up-titrate their therapy.
When it comes to tolerability, I think we should neither forget the data I was showing regarding the role of CRT as an enabler. So after we have implanted a device, still we need to work on optimization of medical therapy, because also, according to the consideration you were making regarding mitral regurgitation, the remodeling induced by the CRT can, facilitate the uptitration and improvement of GDMT in this patient.
And also we were discussing about tolerance of GDMT, but usually we see the patient in the outpatient clinic at rest. But I am a fan of exercise tests for heart failure patients, because in about 30% of them, you can find a atrial chronotropic intolerance. And these patients, they have an improvement in left ventricular ejection fraction, they have a good blood pressure, but they are still complaining of limitation of exercise. It's just because the heart rate increased from 50 to 60, 65, and they are totally blocked there.
Right.
And this device also can be very helpful, because you can program a device with right response algorithm, and so they will increase the heart rate during exercise up to 120, 130, that depends on the programming. So I think also the tolerance should be assessed at rest, but also during exercise.
Completely agree.
Yeah, and I just want to add, the DirectHF program is partly clinicians, but also patients. The clinicians, we tend to focus on events and sudden cardiac death reduction. The patients focus on an improvement in functional status with CRT referral, right? And so I introduced that very early on as well when I'm talking about a potential referral, because that's important in the shared decision-making process.
I would like to echo what you said, Shelley, and coming back to your first slides, you insisted on patient representative in the DirectHF program. Can you tell us what really it brought in the program, and how the interaction with the patient representative really changed a little bit our vision as a physician, as nurses also, on the program?
Well, I think it gave us an important perspectives in terms of the language that we use when discussing device referral, when discussing their heart function in particular, and some, I think, more simplicity in terms of the algorithm as well. The algorithm's actually, in my mind, understandable to patients as well, in terms of the urgency of referral, the technical considerations, and then a really important, at the end of it, is the patient helps decide what device is appropriate for them. So we check all the boxes. They understand the journey that they're going on in terms of consideration of an appropriate device referral and their optimization of their 4 pillars as well. So it was a really interesting exercise. One of my Canadian colleagues, Mark Baines, was part of this group. He's a person with lived experience and has started the Heart Life Foundation in Canada as well. And he's become an expert in heart failure and discussing heart function therapies over the last 10 years or so. So his insight has been really quite valuable.
Yes, coming back to the importance of the patient, I think we all agree about that. It was a very important part, as mentioned by Shelley, in the DirectHF program, because each time I discuss with patients, I learn a lot, because sometimes my speech is a little bit too scientific. And also, we will provide you in a few months a manuscript about the patient survey. And I think it's very, very important, because for me to implant an ICD could take 30 minutes and that's it. But for the patient, he will have the device all his life. And it's something new for him. And I think that it's very important, and it was a value of the DirectHF program to have all these patients with us.
Yeah, we also had women represented as well. And I think this, for me, is really important, because women in general are less likely to receive appropriate heart failure care. And that includes the 4 pillars, but they're less likely to be referred for appropriate device referral too. So I think having their voice at the table as well will hopefully ignite an initiation for more referral for women.
Yeah, and especially we know that also women sometimes are less keen to receive ICD, for example, for aesthetic reason, we can understand. And also to discuss with them now, we can explain them that we have more discrete device, not in the subclavian area. So I think in something that it changed totally now the rate of acceptance in my clinical practice for women to accept an ICD now with a new device.
Have you been checking that? Have you been following that to see if you're increasing the...
Yeah. Some of them were...
We should be publishing this because it's so... And I think maybe perhaps even some community cardiologists don't know that there's been like a transition to subcutaneous devices which will increase the acceptance for women as well.
Absolutely. Shelley, you talked about 3 months. You said, one of your examples, you said, I talked with the patient when the patient has a criteria of CRT. I start GDMT, but I already tell him, and in our paper it's written 3 months. Can you elaborate about those 3 months? Because I hear many.
It's hard.
Exactly, I hear many specialists saying, but why 3 months? Or I mean, you see, I mean, it's important that all of us here we explain why did we choose 3 months.
Why did we choose 3 months? I mean, right? In real life, it's hard to get a patient optimized in 3 months, I think. I know you did the strong HF and you did it so fast.
Daily life.
But in real world practice, it's a little more challenging, except maybe in Sweden, right? The gold standard of heart failure care. You know, getting the message out there to clinicians is going to be important, that this is sort of a change in practice and recommendations. I don't think it's out there. I think people are still thinking 9 months, 12 months for non-ischemic patients. And this has really been a change that needs to be messaged to many clinicians.
I think the answer for me is simple. It was because it was required in the clinical trials.
Exactly.
Somebody put 3 months. If it was 6, it will be 6. And now for the guidelines, they use the criteria of the clinical trial. But I fully agree with you, and it was shown by David Denker in the Protect HF study using wearable cardio defibrillator that sometimes some patients are slow responders, I would say. Some of them, they need 6 months or 9 months to increase their left ventricular ejection fraction. But I like one of your slides, Gianluigi, about left bundle branch block patients. And for this patient, I think that if you have a true left bundle branch block patient, don't wait to implant a CRT. The device will not do anything about the left bundle branch block.
And that's a new message for clinicians as well to hear, right? It's always been this wait culture with the heart function teams, and we're really moving that needle closer to like 3 months or right away in somebody with a wide left bundle. Why are you waiting? I think the data you showed was wonderful.
Completely agree. And in those patients, I think we should really prioritize referral and implantation, and also probably be more aggressive from the beginning with initiation therapies, already considering that probably the therapy will not improve so much ejection fraction. So I think it's a key take-home message. Yeah.
And again, by explaining why we are referring so early, because we already start GDMT and would like quickly to up-titrate, and we need to have this being resolved. Yeah. Very good message.
So I think time is running, so now I will give the floor now to Shelley to give us some key learnings and evaluation. So thank you.
Yeah, so on behalf of the DirectHF program, we are very pleased with the global educational content that we've created. This consensus document from the group of global experts, this figure, I think, should be posted in every heart function clinic, every community cardiologist clinic as well, with regards to the phenotyping of the patient, as Gianluigi spoke to earlier, with regards to ejection fraction, width of QRS, as well as additional features such as genetic testing, high burden of scarring, et cetera. That really defines the type of device that needs to be considered. But you can see here, and as we mentioned during our discussion as well, that either an immediate referral is required in those patients with a very high risk profile, or an urgent referral within about 3 months based on clinical trial protocols. So we're really changing the timing. Remember, in a patient with a very wide left bundle, don't delay referral for CRT, and that we discussed some really important myths that we have to bust within the heart failure community as well with regards to the urgency for device referral. Remember, we're not competing with GDMT here, right? These are complementary therapies that can improve the clinical outcomes of your patient as well as the functional status of your patients, especially those who are getting CRT devices. So it's all about personalized timing. And if you go to the consensus expert document or go to the DirectHF website, which I'm going to show you next on a QR code here, you will in fact have the opportunity to get access to that paper as well. So on behalf of Professor Mebazaa, Savarese, and Leclercq, thank you so much for joining us. Any last words at all, Alec?
I think what we learned is really that we need to work stop working in silo and really having the patient benefit from all this expertise, and just love this session. Thank you so much.
Gianluigi?
My take-home message is GDMT is not only pharmacological treatment. Don't really forget that it's pharmacological treatment plus device.
And mine is that referral doesn't mean systematic implantation, but I think it's important that the EP sees the patient first. So don't forget that EP exists for heart failure as well.
Right. Don't forget, don't delay. Thank you so much on behalf of the DirectHF team. And thank you to Medtronic for sponsoring this session.